Good morning. I am Boris Severinsky from Emory Eye Center, and I am a chief of a specialty contact lens service there. And today we will be speaking about application of specialty contact lenses, and particularly scleral contact lenses in children. So what do we know so far about sclerals in children? I will just go very much briefly about available literature. Basically, up to date, it's two major studies about sclerals. Both of them were done on a prototype of device, which is a large scleral lens, mostly used for treatment of ocular surface disease. And both of these reports come from Boston Foundation of Sight. And looking at their reports on the statistics applications were again entirely ocular surface disease treatments like neurotrophic keratitis, excuse me, or Steven-Johnson syndrome. So these studies look, it's a large group of patients. Again, it's hard to speak about large groups of patients when you fit scleral contacts in children, but both talk about patients under 13, 15 years old with a pretty long follow-up. And the breakdown of the studies is pretty similar. So the vast majority were treated for ocular surface indications, and about 13 to 15% were ocular vision correction, like keratoconus or corneal scarring. In more recent publications from the last few years, one from USA and one from Iran, the studies look into use of a smaller type of scleral lenses, like mini scleral lenses, or regular diameter scleral lenses, and the breakdown was a little bit different. So in these studies, the majority of almost half of the patients, more than half of the patients, were treated for vision rehabilitation for cases like pediatric keratoconus or corneal scarring from penetrating injuries, and about 40 to 30% were treated for ocular surface disease. None of the studies, none of these four major scleral lens studies in kids didn't show any evidences, any accidents of microbial keratitis, which is good. So why do we use sclerals in kids? Foremost, it's pediatric keratoconus, which might be very prevalent in different parts of the world. Secondly, traumatic eye injuries, and of course, support and hydration of the ocular surface in cases of neurotrophic keratitis, Steven-Johnson syndrome, and blepharokeratotic conjunctivitis. It's also found to be useful after congenital cataract surgery and in cases of pediatric keratoplasty. So in this presentation, I will be kind of bouncing back and forth in between the cases and the literature. And one of the studies, actually the Emory study on contact lenses in kids. So I just wanted to show again the design of the study. It was a retrospective chart review that lasted about 2 years. We did treat 24 eyes of 18 patients. All of them were under age of 15. And the age breakdown was from, excuse me, 16 months to 14 years. The mean age of the treated group was about 11 years. So our groups were almost similar. We've had 14 eyes with regular cornea and 10 eyes with ocular surface disease. And again, here you can see basically the age breakdown. So we did have one patient that was 16 months old at the age we did start scleral lens feeding and treatment. So now let's talk a little bit about what is available and what are the available types of contact lenses, scleral lenses for children. So we'll be talking about sealed contacts, which is a vast majority now, versus fenestrated scleral lenses. We'll speak a little bit on how to pick up on how to choose your initial lens, what will be better to use the base curve selection type of fitting or sagittal depth selection type of fitting. Of course, the size of the lens and the peripheral system of the lens, how do we make this lens stay over patient sclera? And of course, what is the best way to put these lenses? Because, as most of you know who is familiar with scleral lenses, this is particular way we should put this lenses in patient's eye. It has to be filled with preservative-free saline. So with young kids, it may be a bit challenging. So just very, very briefly about what is scleral lens. And again, it's a large diameter rigid gas permeable contact that it's fully supported by sclera and doesn't have any contact with patient's cornea. It also clears out the limbus and it maintains this liquid reservoir in between the lens posterior surface and the surface of the cornea. Lens is divided into three major excuse me, zones. The optical zone, which basically is the base curve of the contact lens, which allows refractive correction. Transition zone, the zone that basically connects the optical zone with the landing zone, and the landing zone is a part of the scleral lens that fits over the sclera, allowing to center and support the lens. Speaking about different types, so looking back maybe 30, 40 years ago with scleral lenses, gas permeable scleral lenses just have started. Most of the lenses were fenestrated. To those of you who is familiar with film design for optical measurements. So basically it's a large diameter rigid lens that has a little fenestration hole, diameter 0.5 to 1 millimeter, and this lens is inserted dry, so you don't need a liquid to place this lens, which actually may be very helpful in the little babies or in cases when we cannot really keep the consistent face down position to insert the lens. The disadvantage is it's actually very much complex fitting. You have to do multiple adjustments and modifications, and right now there's very small number of labs that will be able to produce such a lens, and also the cost will be significantly higher. But again, for cases of young children with pediatric aphakia or very young age Steven Johnson patients, it actually may help a lot because the insertion of these lenses, it's way easier for parents. Again, in these lenses, we assess differently or separately the optical fitting, which is this corneal fitting of the optical zone or the scleral zone. So the same idea for regular contact lens, a scleral contact lens, to prevent any possible contact with the cornea, to maintain a healthy tear reservoir, and of course not allow the bubbles that comes through the fenestrated optics to be big enough to block the sight or cause desiccation. This lens is again inserted dry, so basically there is no sealing effect. These lenses won't seal over the cornea completely, but there is a flushing of natural tears throughout the fenestration, which actually improves very often oxygen levels to the cornea. Now, the contemporary scleral lenses are all sealed. So basically you don't see any fenestration of these lenses. And at the moment the lens is inserted, is basically very minimal to almost no tear exchange in between the back surface of the lens, the tear reservoir, and the surface of the eyeball. The advantages, it's a huge amount of manufacturers and different designs available. So basically today you can fit all sizes, started from 13.2 millimeters up to 20.2, even larger millimeter scleral lenses. There's a lot of designs to modify the landing zones and optical zones with different additive things like toric peripheries, microvolt. And basically, the number of modifications will be countless. You can also require these lenses, as I said, in smaller diameter, which will be actually easier to handle by parents and or children, kids by themselves. Disadvantages. It's again lens handling. It has to be inserted filled with saline, and definitely both parents and the child has to learn how to do that. Other disadvantages is actually suction effect because of the fully or completely fully sealed lenses. So sometimes if the landing curves are fitted too tight to the sclera, it may cause some suction upon removal, which may be transferred to emotional distress of both the parent and the child, and definitely leads to drop-offs. So how do we decide which lens should go into patient's eye? You can You can see the child for a corneal topography, especially ages 10 and higher, but very often it's hard to obtain any good measurements. So basically all your decisions, especially in very small kids, will be going by looking at the profile of the cornea, of the profile of the eyeball, which is easier to assess even in very, very small kids. So it's mainly based on external assessment. And again, we can differentiate a little bit in between our trauma patients and ocular surface disease patients. So usually in surface disease patients, you will prefer probably to go with a larger lens to allow for better coverage and for a healthier tear lake underneath the lens. In the regular cornea patients, probably smaller lens will be good point to get started. Also remember, basically after age of 7, the size of the cornea in child will be basically similar to the size of the adult size cornea. So in pediatric keratoconus, you can basically have started with what is manufacturer recommendations with the regular size of the adult lens, and looking both on the sagittal value and the diameter. So again, as we said, the most rapid phase of corneal growth is basically from birth till about the age of 1.5 years. Cornea keeps still changing, and it basically we can count it's like a millimeter of change from age of 1 to age of 6 and 7. Eyelid position and palpebral size aperture also plays a role in your initial decision about the size of the lens. So I would say as a rule of thumb, maybe starting with lenses up to 14 millimeter in diameter for ages 1 to 2, and then basically increase the size by 1 millimeter steps for every 2 years. And again, as a child's cornea reaches the adult size, ages 6 or 7, you can go with lenses of 16 millimeter and even larger. So just an example of 7 years old wearing a 16 millimeter lens in case of post-herpetic herpes virus related corneal scarring, and you see the lens could be handled pretty much easier. So how do we fit these lenses? Let's touch this part a little bit. So we can differentiate our landing of the lens, speaking about tangential type of scleral curves or radial scleral curves. So tangential scleral curves might be a bit easier to assess a good fit immediately using a lens out of the box, because it basically will create a straight line with patient sclera. Also, the advantage of tangential type of landing curves is to reduce suction or pressure over the eye and patient sclera. So when do we use a series of radial curves? It usually will be 2 or 3 landing curves. Again, depends on the size of a scleral lens and depends on the design of the lens. But you can basically manipulating these curves, and as you can see here, I think it's example of one of the maximum lenses. So you can definitely see the difference in curvatures throughout the lens landing. But adjusting the curvature of the curves, you can basically create almost elliptical or spherical optical surface, which also could be following the size of the sclera pretty much precisely. So what do we do regarding the materials? Of course, we'll aim to use the most gas permeable materials, so what's called hyper decay materials. I believe almost every manufacturer now uses at least decay of 97 and higher for their contacts. Boston XO is very common, together with Optimum Extreme and Extra. They see new materials that came recently, Optimum Infinite, that has a decay, if I'm not mistaken, almost 160, which makes it even higher. So the most readily available material, I believe, around the world now, it's Boston XO2, but Optimum Infinite actually provides slightly better corneal oxygen flow. You might find some evitability issues in especially teenagers and young kids that may be more prone to blepharitis. And then actually lower decay materials may behave a little bit better because of the lower silicon percentage inside of the lens material. So just an example of purely wetted surface of a scleral lens, and then you can downgrade a material to lower decay, to going back to more original ones like Optimum X and Boston XO, trying to solve this problem, or a special coatings may be applied to the lens, like a hydropaque coating, or we can actually address the blepharitis in these patients, trying to treat the surface first and before we do any material changes. So how do we set it up? What do we use inside of the room? And basically, it's not really different from fitting scleral lenses in adults, but there is a little bit of tips and tricks that I would like to discuss. You definitely need an extended trial set, right? So if you say patients, you don't want to use a scleral lens with a power of -2 on somebody who needs probably +16 or +20. Also, you should prepare, I believe, both the parent and the patients to what is about to happen, because definitely the lens itself, if even you show it to an adult person, the lens itself look pretty much stressful looking at the size, and especially when you have a small kid that's probably been through or surgery or ocular trauma, and it might become very much emotional. So you have to be quick and address it very much carefully. So what we usually do in cases that we cannot use a slit lamp, I very much like the blue pen light, which helps to assess the lens immediately. For little kids, it's older than 5, I will say, you can do what I call dynamic OCT. So they probably won't be steady enough to see it all the way along to access a good image, but you can at least look at the screen, or even taking a picture of the screenshot of the screen with your cell phone so you can review it later. And again, older kids can definitely sit for corneal topos and OCT later on. And I believe this child, it's about 2. And again, it's very easy also to take an external photo using your cell phone. It just utilizing some fluorescent and blue light. So I just touched already a little bit about the lens parameters. Always try to extend your set. So basically what the manufacturers will give you. And again, I'm listing some companies here. I understand that around the world, you guys may be using local manufacturers. So I'm just listing the ones that are available in the US. But again, most of the manufacturers today, they can bring all type of lenses also from different places. And you can always work with your local lab, instructing them what exactly do you need and what diameter you would like to use. So it's all adjustable. But again, as you see, the small diameters are pretty much available, and even could be done as small as 13.2 millimeter in case of Ocular. Again, for pediatric keratoconus or teenagers, you can basically go with an adult size of the lens, and high and very low plus, high and very high plus and high minus lenses are also very much useful. And don't forget your retinoscope, especially for small kids or for patients with corneal scarring and central scarring. So sometimes if you do autorefractometer over a contact lens, it just will give you misleading information, or it just will be very difficult to access. So retinoscopy in children in contact lenses is a must. So how do we apply the first lens? Usually, excuse me, I usually like the parents to keep the child on their lap, and I will show the lens. I will just basically even do a short, when the child is very emotional, I will do a short demo trying to apply this lens to parent's eye, or just bring it close enough to a parent eye just to give them an idea of what's going to happen. If you do use what I call comfort drops, it's diluted version of ocular anesthetic. So we usually dilute it to 25–30% of our regular concentration. So when you apply it, it doesn't sting that much, but it still provides an anesthetic effect for the next 5–10 minutes. So you can definitely insert the lens easier for the first time, and also it will prevent refractory tearing. And we do use heavier fillers rather than saline. You can use everything that will be preservative-free, like Celluvis or TerraTears type of gels, which is carbon butyl cellulose based, and even you tilt the lens, it still will feel the lens when you put it in. We do use flying baby technique for small children, basically just the parent just holding the child with their back up and just trying to kind of moving it back and forth, and then you just have to follow the child when it's carried by the parent trying to put the lens in. Be fast, be quick, and use what they call the surprise factor. So just speaking with the child or the patient, and just let the parent know to bend the kid's head over and down. And just in this example, this short video, yeah, of course she's not happy, but that's all, it's done. So the quicker you are, the easier it will be going, and then you can start your exam. So again, we touched a little bit about using some anesthetic before you put your first trial lens for diagnostic fitting. It also will help you to access the prescription better because it will eliminate refractory tearing, and you can also access the fluorescent pattern better. Definitely use your phone or tablet, and or parents' phone or tablet, making child also engaged. You can put some videos, some cartoons, so they can watch it during this insertion. I like to put the tablet on the floor, just maybe playing some cartoon or some YouTube videos, and then basically the parent will bend the kid's head down, and then I will put the lens in. Be careful when you pick up your first measurement lens. Again, it's hard to tell what to use immediately, but as I said, maybe just go for, if you don't see if there's significant distortion in the corneal profile, go with the lower sac lenses, because if you had too much of a sac, you may cause some suction to the eye, and then when you try to take it out, it may become very much emotional, and the kid, and especially the parent, initially maybe under significant distress when they see that the practitioner cannot remove the lens. Also try not to use too many measurement lenses, because the child may not stay with you and cooperating for that long. So I'm trying to get at least the first fit, and definitely prescription from the first lens. And even the fit is not ideal, if you need to reapply the lens, use a different sac. At least you already know your prescription, because you know the base curve of the lens and over refraction, so you can adjust it later. So now let's touch some cases. So again, excuse me, going back to our study, most of our, almost 50% of our patients were patients with pediatric keratoconus, and it may start very early in life. I believe one of the patients in our study was 7 or 7.5 years old with a significant case of KC. It's way more prevalent in Middle East, and basically in every area that will have high prevalence of allergic conjunctivitis or vernalis, we will see more prevalence of keratoconus. The reason probably is our eye rubbing, as all of you know, and because child's cornea is also softer than an adult cornea, because it's higher turnover of collagens, it also may be responding to deformation of more and more like a worse type of a response in an adult cornea. So of course, no rubbing should be, I'd say, the parents and the children has to be educated about no rubbing. And of course, because the cornea is softer and the progression is faster, you might see more of a scarring, or definitely more severe cases of keratoconus. So the sooner these kids are educated about no rubbing, and the sooner we do any type of supportive procedures that we'll discuss in a second, it definitely will be greatly appreciated, keeping the child's vision stable. So it's a case of 11 years old. There's actually no history of eye rubbing, and he already has a KC for 2 years. As you see, the cornea is pretty steep. I believe he's here about 70. We did do a trial fitting in the office, and actually his vision was corrected pretty good to 20/30. He's a little bit borderline, I will say, for cross-linking. So again, here's other options, maybe partial corneal transplant, maybe full corneal transplant, maybe still trying cross-link, maybe AP-off or contact lens assisted, and then fitting a scleral lens. So they did proceed with scleral lenses actually, and this kid was cross-linked about a year later because he still kept progressing. And there was, I think this is very important statement by Shadis and Hafizi 10 years ago, that basically they found that progression of keratoconus in kids will happen. It's vast majority of the cases. So there's basically no need to wait till the cornea gets worse and they have more scarring, and these kids has to be cross-linked. Again, just in case of corneal follow-up and progression follow-up. So you see in 12 years old female with Merkel disease, she did progress every few months, diopter steeper and diopter steeper. So even a year ago, it was 51 in the center. Now she's 53.3. And her uncorrected vision also dropped by from 20/40, which is still functional, to 20/200. So probably no waiting, it's better. Again, speaking about rubbing, probably no rub, no cone. It's very, very famous statement now, which is probably holds to be true. Another case of 12 years old from our cohort, from our study, he has allergies and he rubs his eyes. Vision is bad since age of 10. Glasses never fit him. And again, he mentioned you basically cannot do anything with a refraction, with a prescription of 85 diopters cornea. He's not a good candidate for cross-linking. He's too thin. He cannot tolerate RGBs. Actually, it's not about even tolerance. It just cannot stain his eye because he's so steep centrally. So again, next step for you, place it 12-year-old through PK, or still try scleral lens first. So the decision was to try scleral lens holding of PK, and he actually did great. His less steeper eye was 20/25 with scleral lens, and they continue with scleral lens wear. So going back to our study, the mean keratometry of our keratoconic patient was 64, which placed all of them under advanced goal definition. The astigmatism was higher than 7 diopter. Most of them had severe form of the disease, so they cannot wear either glasses or rigid contacts. And they did great with sclerals. The mean vision corrected acuity was 20/30 with the contact lens, which is great. Also in 4 eyes with very advanced disease, with Kmax over about 75, the use of scleral lenses prevented the need for keratoplasty, which is again in this, as you know, in young ages, penetrative keratoplasty may be a risky procedure. And the vision was corrected in the good level. On of them, 6 of them also underwent corneal cross-linking, so, and then scleral lenses were fitted. And probably speak about the new paradigm now in treatment of keratoconus, and same applies to pediatric keratoconus. The progression will be probably faster in pediatric KC. They should go through cross-linking first, and then scleral contact lenses should be fitted. Okay. And again, just discussing the risk and benefits of sclerals in PK. And again, all this the studies show that both cross-linking and scleral lenses shown to decrease the rate of PK in keratoconus, and the same applies to pediatric patients. Another case from our study, he's 13, and getting rapid onset of keratoconus, he presented with corneal hydrops and discement membrane rupture. He will managed conservatively for corneal hydrops with hypertonic saline steroids and cycloplegics. And despite of the, basically this is the acute presentation, of course, but it left him with a small scleral, relatively, I will say small, medium-sized corneal scar. But despite of the scar, his vision actually was corrected to the initial visual acuity because of the flattening effect. And sometimes you will find in eyes after corneal hydrops, and especially in kids, because again, the cornea is a bit softer, that it flattens the scar, actually flattens the central cornea. And then over time, this scar also became less dense, like a fading of the opacity, and then we can achieve good visual acuity with the scleral lens. Speaking about special population, we can also, and special population may like Down syndrome, and kids with autism may also have higher rates of keratoconus. This child had one eye, basically, vision was lost because of the very dense central scar and high drops. But in the other eye, his parents are able to apply a scleral contact lens, a small diameter scleral contact lens, as they use a gel filler instead of regular saline. And in such a way, they can apply this lens in basically in straight ahead position without making him bend, because they cannot really make him to bend for scleral lens placement. And again, we use what's called dynamic OCT to just access the imaging throughout the exam without really being able to capture, but at least you can take a picture with your phone and see it. Down syndrome, she's not really young, but just to emphasize that again, scleral lenses could be easily worn in patients with developmental delay and autism if you do have a good supporting K-Tech caregivers or takers. So another example of a slightly different scleral lens, it's what I call soft scleral lens. Basically same idea, it utilizes a scleral support, and maybe if you can see it here, so this lens moves, right? And you see the fenestration, and actually the oxygen can move through this fenestration holes. So this lens also stays over the sclera. It has some minimal but still tear lake underneath, but this lens could be inserted dry. It's made out of silicone hydrogel, so basically you can fold the lens and insert the lens being folded underneath the upper eyelid. And here's a patient with, again, with Asperger's syndrome. He's 17, he has central keratoconus, history of eye rubbing and allergies. He's been cross-linked, but he still cannot achieve a good vision because he cannot use RGB, he cannot tolerate, he cannot handle scleral lens insertion because of the complexity of the insertion, the fillers, the liquid, all the suction cups. And we did try this silicone hydrogel soft scleral lens, which he doesn't need to do any liquid inside, and he can get 1/40, he can try with the contact lens, which is great. Speak about PK. So what do we need in PK? We actually need a good oxygen transmissibility of contact lens material. So definitely XO2 or Optimum materials will be of preference. You need what's called fluid ventilated feed, because you're definitely interested to get some liquid underneath the lens, bringing more of an oxygen to the cornea. And just another video. So it's not really sealed lens, so we're trying to go a little bit larger here, but after the lens being in the eye for about an hour, you can still see some oxygen, some tear flow underneath the lens edges, so we can increase the oxygen levels. One of our patients with pediatric PK, so it's more complex case, I will say. It's not very typical. So he's 4 weeks old and huge dermoid, and he underwent multiple surgeries with ocular surface reconstruction first, and then DALG with scleral patch graft just to again reconstruct the ocular surface. And after all healed, he underwent optical PK, and here's how the eye look after PK. But again, it's a deep amblyopia. It's a huge astigmatism on retinoscopy. This eye also an ET in esotropia. So every attempt to place a rigid lens was unsuccessful. The lens just kept popping out. And just, just before giving up, we did try a small diameter scleral contact lens, 14.6 millimeter, and it can stay. And again, we can fully address this huge astigmatism. So definitely there's a lot of challenges placing these lenses, and she also underwent through episode of rejection, but still we are able to take care of the optical correction of this high astigmatism, and he's doing great. So in other case, he's 11. He also has autistic disorder. It's a trauma, so he's also aphakic. Has traumatic glaucoma. Glaucoma is under control, and see how. And he actually can handle his lens by himself. And again, he's 11. It's adult size scleral lens, 16 millimeter scleral lens, and after 2 years of using the lens, the graft is still clear, which is great. So speaking about aphakia and penetrating ocular injuries, it's very common. I'm speaking mostly about ocular injuries. It's very common, and mostly affect boys, as you may imagine. And most of the injuries are perforatic injuries of the cornea, according to one of the studies. And I just want to go briefly again through some of the cases in our studies. So this child is 8. Corneal laceration resulting in corneal scarring. A lot of it is irregular astigmatism, and just looking at this cornea, it almost looks like keratoconus. And his case marks, it's about 54, but it's just basically because of the scar-related stiffening. He also got a cataract surgery and then YAG laser after cataract surgery, uncorrected visual acuity, it's 20/100, and after scleral lens fitting, even seeing this huge scar going through the pupil, he's 20/25 with a contact lens, so which is great. In other case, a ruptured globe due to fall. He's 8, he's aphakic. He also get retinal detachment and 2 repairs of retinal detachment, resulting in very much irregular sclera, some scarring and elevation, as you can see here. So we actually fit him in a large diameter, 20 millimeter lens, also trying to center the lens because of the high prescription and scleral irregularity, and he's correctable to 20/40. So basically, it's very, being aphakic and seeing the scar probably is the best way, just to keep him in contact lens without performing any combined type of surgeries. Another case of corneal laceration from a sharp object, and she's aphakic, lens was expelled, and you see how heavy is the scarring. She also didn't heal well, and she was the wound was dehisced, and she was resutured, and she's very apprehensive trying lenses. So we did do, I believe, 4, but I believe it was more than training visits with her parents till they finally been able to get the lens in, and again see how bad her cornea look, but the vision acuity is 20/40. So again, in this case, again, and it's hard to tell even she goes through PK, but how it will survive and what vision would be. But again, she's 7, she's already 20/40 with a contact lens. They're doing patching of the other eye just to prevent any possible amblyopia. And at least for the next 8, maybe 10 years, the contact lens will work till any other decision will be made. Again, going back to our study, basically in almost all cases of penetrating injury in scleral lenses eliminated the need for PK. Another case, aphakic scleral lens, see 4 weeks old, congenital cataract, already has megalocornea because of the elevated IOP. They did well with a rigid lens till about age of 6, and then lens start popping out, probably because of the eyelid architecture changes and more lens awareness on the child side and eye rubbing. And then he was fitted in 15-2 diameter lens, which stays pretty well. And of course, we need to overcorrect this children trying to improve their near VA, so as a part of anti-amblyopia therapy. Like I'm just saying, even in these ages, is the scleral lens insertion is and fitting is doing well. And of course, again, as I said, we'll keep it slightly overcorrected, trying then to titrate the power slowly to keeping this in emmetropization of the other eye. And probably the final few cases of pediatric ocular surface disease, which again, for sclerals, it might be everything. We do see young patients with graft versus host disease. It might be Stevens-Johnson syndrome. It might be neotropic exposure keratoconjunctivitis due to eyelid surgeries or acoustic neuroma surgeries. We do see many cases in Georgia of blepharic keratoconjunctivitis. And again, there's a treatment with scleral lens. It's basically the same. It's both bandage effect, but also vision rehabilitation effect, because most of these cases will present with some degree of corneal opacity or corneal irregularity. And speak about our study. 8 patients were below age of 10, again, which makes the contact lens, scleral lens fitting challenging, but all of them did well with it. We had 3 patients with neotrophic keratitis for various origins. Mean visual acuity was 20/60. Again, let's don't forget amblyopia in these ages and also corneal opacification. But all of them were able to continue scleral lens wear. Even so, it was a bit shorter, again, because of the inflammatory nature of the condition. So the wearing time was shorter in ocular surface disease patients rather than in irregular cornea patients. But all of them showed an improvement in ocular surface appearance, and in all of them, vision also was improved, and no one showed any we didn't see any cases of microbial keratitis in our study. So probably most interesting case here. She's 6 in 2020, and she got this very nasty HSV keratitis of the central cornea. Of course, decreased VA, surface is very dry, has arteriostromal scarring with regular astigmatism. She was treated conventionally, but unfortunately, it didn't change the appearance of the scar. So she was fitted in a scleral lens, which improves its dryness and the surface appearance. Vision is still in 20/40ish, and they've been doing patching of the other eye. And again, here's her topa. It's pretty much high regular astigmatism. But look at the picture from 2020, and then we go to 2021, using scleral lens for a year, and already the opacity looks a little bit lighter, less dense. And then we go to 2022, and look how her cornea looks now. And just going back for a second, 2020, 21, 2022. So there's some documentation in the literature also, and of course her vision improves. There's some documentation in the literature that I'm just keeping this one at a similar appearance, but this one important to talk about. This few reports from Boston side that showed improvement of corneal scarring in patients with NK and Stevens-Johnson syndrome from use of scleral lenses. And again, think about the protection effect, and constant hydration probably decrease the inflammatory phone over the cornea in cases of surface disease. And then basically the lens use may help cornea to probably cause some faster keratosize or collagen exchange throughout the cornea. So the scars usually in kids usually get better over time. Again, it's one may advocate it just in natural process. We also may advocate that it happens from the use of a scleral lens. Probably both are true, but we definitely see scarring improvement in patients wearing scleral lenses as a bandage lens. Few are cases of blepharic keratoconjunctivitis. As I mentioned, it's pretty common in Georgia. So when the disease is active, of course, it should be suppressed first with the steroids and eyelid treatment. We do start scleral lenses pretty early in these patients. even it just shows some signs of improvement, again, for both reasons, protection and also separation of the patient's cornea from an eyelid. And of course, we keep them on prophylactic antibiotic. And at the moment, disease is under control. Scleral lens basically serves as a vision correction lens. So in the time I still have, I would like to go through maybe a few cases of BKC. 9 years old, tearing photophobia from age of 9, been treated with conventional lubrication, and then when it got worse, steroids and restasis, still worsened, and then she presented with bilateral. The appearance is similar right and left eyes, unfortunately. So her vision was significantly decreased, and his hetopa, and both eyes had the significant central opacity. We did started scleral lenses, and in 3 months, she didn't show any changes to the appearance of the ocular surface, and vision improved to 20/40. Another case of 8 years old with recurrent lesions, BKC and active KNV, been going for a long time. She's on restasis, she's doing all the surface disease treatment, on and off steroids and azithromycin for the last few years. She already has decreased corneal sensation because of the recurrences and senile scarring, and of course decreased visual acuity, and again pretty much distorted topography. And we did start this scleral lens. Her cornea also improved. Again, I'm just bouncing back to show you this type of a scar density before we started scleral lenses, and this is how it looks now. Vision is good, and she's actually able to handle insertion of the removal of the contact lens. And the very last one I would like to share, I just want to see this video of a Stevens-Johnson syndrome patient, which is, I believe he is 10 now, and look how easy he can do that. And he's been doing it for at least the last 2 years. Boom, it's in. So, speaking about scleral lenses in kids, of course, it's challenging, and of course, it requires time, but it's very appreciated. It's a great treatment tool for both vision restoration and protection of the corneal surface. And as you just saw, improvement of the corneal surface. And it just needs time and proper education of both the child and the parent, and then these patients will pretty much appreciate it. And let's go to our question and answers. So I have a question about minimal corneal thickness to proceed with scleral lens. I don't think there's any limitations for a corneal thickness standpoint. So if cornea is compact and you don't see an epithelial defect, basically you can proceed and feed scleral lens safely on this eye. Okay. No other questions? Disadvantages, I will say, probably depends on the country. Sometimes the cost might be actually debilitating. Again, I can speak from the US experience. The cost might be debilitating. Very often insurance companies won't cover for scleral lenses. Fitting, it may be, it may take time to your learning curve requires some time to going through fitting, learning how to fit these lenses. Sometimes it's more complex, especially if the sclera doesn't have has a pretty significant asymmetry. It may take time to learn how to fit it correctly. But again, comparing scleral lenses with the rigid gas permeable contacts, the main advantage, again, I speak about advantages, it's comfort. And also, again, speaking about the surface disease, its protective properties. Sometimes with the very initial cases of keratoconus, scleral lens might not allow same visual acuity as a rigid gas permeable lens because absence of full corneal contact. So sometimes we need this kind of flattening effect from rigid lens. So, but this is basically the only view I can say. And I have to say, I really see how the last 20 years, the specialty lens fitting moves from rigid gas perms to scleral lenses, and even patients that have been wearing specialty soft, many of them now wear scleral lenses. So this equation about Ross-K semiscleral lens, as it sounds, it's not full, it's not a real scleral lens. It's I believe the diameter is 13 millimeter or 13.2. So basically, it's fitted towards the peripheral peripheral cornea, vaulting minimally the limbus, and it basically doesn't have a full support over the sclera. So it still has liquid reservoir, it still has separation over the central cornea, but it has some type of a contact over the peripheral cornea. Limitation of scleral lenses. Very often you cannot use it when the surface it's really inflamed, or you have a patient with PK, with badly functioning endothelial cells. So if you do put a contact lens on the PK patient and you see macrocystic edema or any beginning of swelling after maybe 30, 40 minutes, and I usually like to leave when we do fit a post-PK patient in a scleral lens, I tend to leave it longer in the eye just to see how the cornea will respond initially. So if you see any type of edema after about an hour, let's say it's just a no-go, probably rigid lens will be safer alternative. Yes, we definitely can use scleral contacts for corneal scars. So basically, if the cornea already had healed and again the epithelium is intact, it's actually for vision rehabilitation. It will be a good option because it's not just vision corrections. Very often, again, it's just the presence of the lens and the bandage effect from the liquid behind the lens may help with this scar fading away. So equation was the minimal age. So again, one of the patients in our study was 16 months old. We do have 2 years old now, the aphakic patient, but basically, again, at the moment you have parents that can cooperate and are able to perform insertion, you can definitely fit it. Okay. Just a minute. How long can we keep the lens thin? So for surface disease patients, it may be a bit trickier. So if they can do 8 hours and the eye looks quiet and clean, and it's not making too much of mucosis, basically no increase in inflammation, we usually recommend to do it for 8 hours and then take it out if there's an option to take it out. If child is at home and parents can do that, clean the lens and refill it with a new liquid, put it back in. So if they can achieve 10 to 12 in surface disease, it's wonderful. Keratoconus patients, basically as needed. So if they need it for 12, 14 hours for school, just go ahead and do that. We still need, still probably 14, 16 will be the max. But again, you have to watch these patients closely to see how it will respond. How long the scleral lens last? Ideally, change it every 2 years, 2.5 years, and even not because of the excuse me, changes to the lens shape of prescription probably will hold the oxygen transmissibility. Usually it will lose about 50% of oxygen transmissibility will go down after 2 years. So if you do have a patient with corneal transplant, change it more often. If you have a stable patient, patients with stable keratoconus, and the cornea look good and the lens look good, you can do 3 to 4 years. It may help actually to repolish these lenses. Patients with keratoconus, many of them will have any type of allergic response with the mucus. So if you can do some lens polishing, it actually may help to expand the durability of the contact lens. But again, I will say up to 3 years better off to change it. Okay. I'm just trying to go through the rest of the question. No, the same question about corneal scarring. Yes, we also see the same in adults. That's actually what makes things that actually there is a lens effect, because in adults, the collagen turnover is very slower than in children, but we still see fading of the corneal scars. So probably it's still a scleral lens effect. So yes. So question about detailed session about scleral lens fitting for keratoconus. I will say I believe the cyber side will be able to address this question. Scleral lenses now, I believe it's globally available, because I'm hearing reports, looking at the literature, these reports now coming from everywhere about using scleral lenses. So it's a very good question about IOP and scleral contacts. It's never been really proven with no large-scale studies that the IOP goes significantly up. Most of the studies, and most of the studies done on healthy subjects when the lens placed and then IOP merged again. So most of them, even the studies that show increasement in the IOP, it was very insignificant, about 1 point. So I will say it's more about the fitting of the scleral lens and not just the presence. So if you do have a contact lens that's so tight around the limbus, and you really see how does it make all the limbal sclerae and the paralimbal cornea to come up because of the lens suction effect. So it definitely can do some changes to the trabecular meshwork, at least temporary changes because of the pressure effect. So it's more about not just the modality, but how exactly the lens is fitted. What should you take care for fitting scleral lenses? I think is the corneal curvature. Good question. You actually don't really need the corneal curvature, because it's mostly about the elevation. So if you have a pentacam and you have an elevational map, you can base your lens fitting on the pentacam, but it's basically observation. And for again, taking pediatric patient, taking measurements may be challenging. So that's why your external observation of the corneal profile will be much helpful. And fluorescent patterns. So again, use the fluorescent already inside of the contact lens. Use your pen light just to have an idea about how bright you see the fluorescence, so you can decide if you need to go closer to the cornea, further away. Some children can also, 3 or 4 years old, can sit for a slit lamp exam. Antibiotics. So it depends. If it's just a surface disease with a bit of a punctate staining and we do use a scleral lens, usually do prophylactically one of the fluoroquinolones like moxifloxacin, ciprofloxacin. One of the advantages of moxifloxacin or branded bigamots is preservative-free. So you can also put a drop of a moxi inside of the scleral lens balls throughout the daily wear. Step in starting scleral lenses from scratch. There's a lot of webinars, I believe, on how to start a specialty lens practice. And again, depends where do you practice. So different countries will have different labs, but it's already everywhere. So I believe you just have to talk to your rigid or scleral lens manufacturer to see what is available. And also many companies will bring import different products from Europe and US. Over glasses, what is the advantage of scleral lens over glasses? Again, sometimes you cannot just correct vision in glasses because the cornea is so distorted from corneal scarring or keratoconus, and even with the surface disease patients. So it will just improve visual acuity much significantly. Okay. Advantages of scleral lens overnight, yes. If there is a significant or non-healing epithelial defect, or in patients, mostly adult patients with pemphigoid disease, or very bad cases of Steven Johnson, we do use modality of flipping lenses day and night time. So they use basically the same lens, or again, any type of exposure when you cannot really protect the cornea during the bedside. We do use two lenses, same lens. They wear one lens throughout the day. They take it out, put it through cleaning process, and they use the second lens that already been cleaned to do it for bedtime, and then vice versa. Of course, they do prophylactic antibiotics in both cases. So we do provide keratokeratology in our clinic, but we do not treat kids with orthokeratology due to safety. All right. I think we're good with everything, and maybe if we have maybe a minute or two, I just wanted to show you, I just put it inside of the presentation, but how you can actually improve. I'm just going back for the share my screen. Oops. I just want to show you a little bit, a small tool, what you can do for your patients, especially kids, trying to improve it, improve their comfort with the contact lens. So for those of you who fits contacts, I believe you do some modification in office. We do roll and polish edges on all of our contacts, but this is just an example of a scleral lens. And again, it's important for everyone, for adults, but definitely for kids to get the best initial comfort. Very often when the lens will come from the lab, it will have like an anterior displaced apex or knife edge looking apex. It might be a bit too much for a child, speaking about emotional distress and comfort levels, to feel comfortable about this type of an edge. And if you just roll this lens throughout regular polisher, and most of the labs will have this polisher available, see how round it is now. So this is basically can remove a lot of discomfort on the patient side. And again, I'm speaking for both adults and children. So just maybe a little tip. And again, we did speak about the challenges. So I will stop my share here, and maybe the last question, age. Not really. So again, it depends on the condition. If you really need to use it for like case of aphakia, or somebody with corneal transplant in very young age, and you can do a child cannot hold glasses, or will be or the surface of the eye is so much regular that you cannot do glasses. Sometimes you just don't have any other options. So I think we can stop here, right? And thank you so much for your attention. I apologize for my voice, but hope it was helpful. Thank you.